Lumpur, and by chance having an opportunity to talk to Dr. Viji, whose bio you would have heard earlier. So I'm just gonna get a bit of an understanding of your background. So there's 25,000 gynecological laparoscopic procedures that are performed in Australia every year. Large studies show that the rate of complications in laparoscopy, I should pronounce that properly, is less than 1%, which is 1 in 100, which is fantastic to hear. Now, you have a very impressive bio, you're a multilingual professional, and you have extensive experience in the field. It's pleasantly surprising to hear of the less invasive techniques that are being used by the Klein Clinic. So perhaps I'll start by asking you and for you to provide the listeners with a bit of an insight to how you find yourself as the caring gynae.
Thank you, Vadi, and thank you for giving us this opportunity or giving me this opportunity to actually present myself and our work that we do over here in Kuala Lumpur, Malaysia, in the Transit Lounge podcast. Going back to see that, Australia is doing 25,000 procedures and the complication rates are only about 1%. But I think it goes across the board because it's an evolution of the technology that we have beginning to encompass in our work, as well as the training which we have had to undergo to arrive at this stage.
Right.
My story actually goes back when I first started in the year 2000 as a gynecologist, as a budding gynecologist in the state of Klang, where I still currently practice as well.
Right.
And Klang is one of the most busiest hospitals in the country in terms of the workload that it shares for the government sector.
Okay.
We are the third busiest hospital in the country after the hospital in Lika, which is in Borneo, and the hospital in Johor, which caters for a big migrant population, as in the Indonesian workers and things like that.
Okay.
So Klang being the richest state in Malaysia, and I mean, in place in the richest state in Malaysia is in Selangor.
Okay.
It was the only state hospital which covered a population of about almost 1 million to 1.5 million people. And although being the richest state in Selangor, we only had one state hospital at that point in time in the year 2000. And that gave me a lot of opportunity for clinical exposure as to whatever that we can do in obstetrics and gynae. And our patients used to come from the western coast of Selangor, which actually covers a big part of the Straits of Malacca. And they did not have access because roads were poor and things like that. So there were certain times where we had to go to those hospitals and treat those patients in the rural centers as well.
Right.
If they needed bigger operations, then they all had to come back to Klang again, right? So, like I was saying, it being the third busiest hospital in the country, we were a training center for the universities, where we had University of Malaya sending their medical students to our center. We had all the surrounding universities using our clinical work as exposure for them to gain insight into the world of obs and gynae. To give you a sort of like an insight into the number of deliveries, we used to do about 50 deliveries per day.
Wow.
Which is about 16,000 deliveries per annum. So that's a huge number if you were to compare it with the developed countries.
Yeah. So there's a real trust of the people coming into that.
Well, kind of trust if you may, but you didn't have a choice.
Okay. Okay. Yeah.
And they came to us because we were the only access to in terms of the bigger operations that they were sent to hospital to do.
Right.
And if the most of them, mind you, Malaysia has got one of the best healthcare systems in the world, where we have got a very good outreach to the rural population.
Okay.
Which means we have a rural clinic every 5 kilometers away from each village, so to speak.
Okay.
If you had a cough, cold, and fever, you will reach the rural center, and that'll be manned by a medical officer or a medical assistant. And they will be able to give you the basics like a cough mixture or a paracetamol or antihistamine just to settle something.
Yeah.
But if you needed something which is a bit more intensive as an antibiotics or you needed hospital care,
Right.
then they would have to refer you to the
Close.
close hospitals. And we also had what is known as traditional birth attendants, TBA,
Okay.
where they were these ladies who had motorbikes.
Right.
And in the motorbike, they had a small carriage in front of them, and where they put every instrument which they would actually use for deliveries. And they will go and deliver in their own house, in their own village. I mean, if the person was staying in the village house, the midwife,
So the midwifery sort of.
midwife
So-
services will go there. And if they find that, this person cannot deliver in village, he has to be transferred to a hospital, then we transfer back to the hospital.
Right.
We had a brilliant system, and this was introduced to us in 1963, where we had a color coding system.
Yeah.
Where there was risk stratification of the antenatal population.
Okay.
So if the antenatal population is, they were very low risk, they could be attended to by the traditional birth assistants or the so-called village midwives.
Right.
If they were color-coded green and above, or green, there were different colors which they gave those on. So the patients knew that they can either deliver in the village themselves, or they could go to the nearest hospital, or they can go to the state hospital and things like that. And of course, if you needed a cesarean section, if you needed a breech delivery, then you would definitely have to go to the state hospitals. So the patients knew where to go, and at the point of delivery. With this, we managed to reduce our maternal mortality rates to less than about 3% in the region, in the Southeast Asian region, comparing ourselves to Vietnam, Cambodia, Philippines, and things like this, just because of this color coding and this risk stratification that we gave to the villages and things like that. So we do have a very good access to care, but we didn't have access to technology because of the cost of the healthcare was, something that the government couldn't cope up with, right? So being in Klang, although it was still the richest state, we found ourselves, having to provide care with bare minimum. And I was the only gynae oncologist in the state of Selangor, covering the whole population in that area. And hours were very long. I used to work about 12 hours per day and things like that. So when I had an opportunity in 2005 to go to Glasgow to train for my gynae oncology training. And when I went over there, they were able to teach me gynae oncology. But by then, I had a bit of access to laparoscopic services in Malaysia, just because of my own interest as well.
Right.
So and they were surprised because I was coming from
India abuse.
And in their view, a low income country.
Correct.
And I had done something which was, technologically advanced as far as they were concerned.
Right.
But there was a problem of working in UK because access to technology always came with a certain set of guidelines.
Right.
Whereas the Southeast Asian country didn't have all this sort of like rules and laws and guidelines to follow. So if someone introduced something, a new procedure today, tomorrow if someone wants to adapt it,
they could.
There's a good to it and there's a bad to it.
True.
It's not regulated and things like that.
Yeah.
So you find countries like India and China progressing very fast in terms of, but they've also got their morbidities and mortality. One speaks about.
Yeah.
Right? So
like in Australia, you wouldn't find that because
you can't find it.
Yeah, the standards and the expectations and accreditation really pushes these, anyone picking up a procedure and doing it.
You have to be able to answer.
Correct. You're held accountable.
Held accountable.
Yeah.
So that sort of what do you call this? Is a good system because you're able to audit what you do.
Correct.
And you know whether what you've done is right or wrong, or it could go the other way in terms of suppressing
Correct.
the progress and as to where the rest of the world is going. You know what I mean?
Yeah. And often access, if I may just interject, I really like the concept of how there's such a good system for those living in regional rural parts of the country. Because one of the things that Australia struggles with is providing adequate access to people living in regional parts of our country in Australia. And being able to sort of provide, like you said, just every 5Ks, you've got someone who could meet your needs from a medical perspective. And you only really need to get to the public hospitals if there's a dire situation. That's pretty good to hear, and it's been running for such a long time. So do they still do that, or is that sort of
Very much so. I mean, if you will go to Borneo, which is a big part of Malaysia now, if you go to the eastern states of what they call the Sabah and Sarawak,
Right.
there are doctors who travel still in boats to go to their hospitals on a daily basis. Their mothers would travel almost 24 hours to 48 hours to get access to their care.